Good morning, everyone. It's my pleasure to join you in this mini-symposium talking about management of brain tumor, and my topic will address stereotactic radiosurgery. So my disclosures, I work at the University of Rabat, Morocco, for a non-profit university neuroscience center, which is working with the gamma knife since 2005. And we developed a partnership for training and education with the Electa. And just to say that all clinical cases presented here have been treated in our center. So as you all may know, and this is the subject today, in the last decades, radiosurgery is used widely as a treatment for several benign and malignant tumors conditions, beside, of course, of surgery and medical treatments. So radiosurgery is a subject today because it can be quite attractive and fashion. Many readings we can find in the literature saying that radiosurgery is surgery without anesthesia, without incision. Radiosurgery is powerful enough to destroy undesirable tissues, and of course, no lengthy post-operative care, no loss of productive life. So lots of claims concerning radiosurgery that make it very attractive. So in our area, the main problems that may be difficult to solve to implement this kind of technology is, of course, the cost of the equipment, the access of the population, and of course, sometimes the choice also of the equipment can be questionable. So in this presentation, we will go around all these techniques. As you all know, there are several technologies, but I'm going back to the beginning, since gamma knife radiosurgery was described by Lars Lexer in 1968, which introduced this technology, and this is of course the techniques we are using here in Rabat. So the idea of Lars Lexer was to prove that it was possible to operate on the brain without opening the skull. And in his definition, he described radiosurgery as the delivery of a single high dose of irradiation to a small and critically located intracranial volume through the intact skull. So by definition, we have to make difference between radiosurgery, which is single session, just like any other surgery, and with anatomical selectivity, and radiotherapy, which use fractionation and biological selectivity. Another aspect to take into consideration is do not mix radiosurgery, which is the single dose, with other techniques of stereotactic radiotherapy. Could it be hypofractionated or hyperfractionated, and other techniques of conformal or conventional radiotherapy. So radiosurgery gamma knives stands in the highest precisions, as we will see. So regarding this principle of biological selectivity versus anatomical selectivity, which is characteristic of radiosurgery, when you have a lesion and you treat it with radiation therapy, you are treating the lesion and some surrounding brain. So you need to do fractionation and use the capacity of normal cell reparation to treat the lesion while sparing the brain. When you're doing the radiosurgery techniques, you can treat, thanks to the technology, only the lesion and sparing the brain, which is just like any surgical procedure we do as neurosurgeons. So these are the main principle. For the gamma knife, it's used the principle of the prime beam, crossfire beam principle, which allows to have in the focal point the maximum of irradiation, which is the sum of all these ray fields. And when you consider the dose distribution, you have this high fall-off dose, which allows you to have the maximum dose at the center of your focal point, while when you go out of the lesion, the radiation decreases very fast. So this is what allows you to treat the lesion sparing the brain. Another fact linked to the radiobiology of radiosurgery is that when you are treating a benign lesions which have this alpha beta ratio which is quite low, the quadratic linear equivalent dose between radiosurgery and fractionations make it a huge benefit for low dose of radiosurgery compared to the equivalent dose of fractionation. So if you have to treat a benign lesion with 20 gray in radiosurgery, this would be equivalent to almost 100 gray in radiation therapy, which is of course non-feasible. So of course there have been a huge evolution in the technology and machines during all these years. So since the beginning in 1960s with the U model, today we are having the icon which have been launched since 2015, and there have been a continuous progression mainly on the aspects of technology regarding informatics and robotics that allow us today to have this generation, which is the icon, which include CBCT and a camera, allowing to treat or even frame less the patients. So these are the main adjuncts with this new generation, the cone beam CT and the high definition motion detection camera. So if you consider the classical workflow we had, first we were fitting the frame and the local anesthesia, then doing the imaging, the planning, and then the treatment itself. Of course, when we have pediatric patients, we can do the procedure under general anesthesia. But with this new adjunct now, we can, of course, treat without frame or with the frame. So we have both possibilities. And thanks to the inbuilt CT scan, we are able to have a non-stereotactic MRI, non-stereotactic imaging that will be implanted in the treatment and used the day of treatment. So it gives much more versatility in this workflow. So when we are treating with the frameless, we are first putting the frame, which is like a conventional frame from radiation therapy with the head support pillow that makes it very stable and allows minimal movements. And here we can do a CBCT, as you can see the quality of the imaging. Then we fuse the treatment plan on the position of the patients on the table, and then we can treat with continuous monitoring of the patients, and usually we will have less than 0.1 millimeter of movement allowed. And of course, the question of frame versus the mask can be raised about accuracy. So as you all know, if we want to have the best accuracy, the frame-based techniques remains the gold standard. And if you are using the mask, you will lose, and you will be, you have to be aware that you are losing some degree of accuracy. And if you are treating, of course, a trigeminal nerve, which is about 5-6 millimeters, if you are having an error of about some millimeters, you can have a lack of those up to 80%. So for very tiny lesions, this accuracy is mandatory. And of course, with the icon, when compared to the Linux, the systems built-in allows an accuracy less than 1 millimeter. So we are still in the radiosurgery field, which is a very high accuracy. So regarding these technical aspects, Lars Lexell used to say that the tools used by the surgeon must be adapted to the task, and where the human brain is concerned, no tool can be too refined. So we are, of course, having a very good technology, but we still need to develop and have maybe the best. So now, for which indications? I want to insist here that this tool needs to be managed by a multidisciplinary group. So all our cases are discussed in multidisciplinary staff before taking any decision for treatment. Of course, as we say, a fool with a tool is still a fool. So here are some cases that are clearly not eligible for radiosurgery and should be operated on as usual. If we look at our indication and experience in Rabat, since June 2008, we have more than 3,000 cases treated. Most of them could be AVM, but second comes the benign tumor, which is the first indication of this technology. So some illustrative cases. Here we want to emphasize the principle of micro neuroradiosurgery, which is the field of application of this tool. So radiosurgery, as I would say, many surgical aspects, is highly technical and of course operator dependent. So here the training and for using of these tools is of high importance. Example here, the best example of a benign tumor, which is the vestibular schwannoma. You can see here, as has been shown, the cochlea, the facial nerve, and the acoustic nerve, and then the tumor. So we can build a dosimetry while sparing all these very important structures. And the dosimetry in gamma knife radiosurgery is based on association of multiple shots, which leads to the final isodose here in yellow. And it is considered as a multi-isocentric dosimetry. Using the capabilities of the gamma knife, we are able to spare, as you can see here, the cochlea, thanks to these adjuncts we have in the machine, which allows to use some sectors of irradiations while closing others, and this allows to spare perfectly the critical organs. And you can see here some typical results about treatment of vestibular schwannoma. What we see usually is tumor shrinkage that will appear with time. Here the follow-up at 1 year. Then you can see here another case with a follow-up of 4 years. So usually we can see a shrinkage of a tumor with time. And this is from the literature, as we observe, that most of the series will have rates of control that are beyond 90%, which is the usual case for these benign tumors. And here, the usual course, we can see when we follow patients that before radiosurgery, the tumors have tendency to grow. So when we treat, then we can observe a continuous decrease that will last for long term. And beside the tumor growth control, in vestibular schwannoma, we can also address the hearing preservation, and this is thanks to this capacity of the machine to spare perfectly the organ at risk, here, namely the cochlea, that should receive less than 4 gray to be able to have a good sparing of the hearing. And you can see here the statistics. if we are treating with a good hearing, we can have probability up to 80% of preserving hearing. So here, of course, the level of hearing at time of treatment is very critical to be able to spare hearing. So the better is the hearing at time of treatment, the best we can spare it. Regarding pituitary adenoma, here also just to emphasize some features of the gamma knife, which will allow us to treat some critical lesions that are very close, as you can see, to the optic pathways, while perfectly sparing these optic pathways and preserving vision. So here, as you can see in a T2 image, you can perfectly define your lesion and the optic pathways. Then, of course, we use the CT scan to have the bony delineation of the sella and to have a precise and control of the MRI to be sure of the localization of the lesion we are treating and the optic pathways. The positioning of the frame is can help also by giving this angle. As you can see here, we can use the angle of 70 degree on the machine. This angle will allow you, if you look here, the low dose is coming across the optic pathways, but when you change the angle, you can make the fall off of those parallel to the optic pathways, and then you can drop the dose received by the optic pathways from 7.8 gray to 6.4 gray. Another adjunct is this dynamic shaping features that allow us, as I told you, to close automatically some of the sectors, some of the rays of beam. And then, as you can see here, when you have the optic pathways that are involved by the low radiation here, you can use them or define them as organ at risk, and then the software will propose you to spare these optical pathways by shifting, as you can see here, the dose using these levels of dynamic shaping until sparing perfectly those optic pathways. And what is really remarkable about the technology is you can go like here in a functional pituitary adenoma from 25 grays to less than 3 grays on the optic pathways in less than 2 millimeters. So this is something that we are using on a daily basis when we are treating lesions around the sella, which are close to the optic pathways. And you can see here, after 3 years, the decompression of the optic pathways and the volume reduction. This was a case of a meningioma. Here, of course, we are using the combined treatment techniques for these big lesions. Then to reduce surgical morbidity, we are first doing surgery to remove the large mass in the petroclival region, and then, of course, treating the remaining tumor with gamma knife to avoid any recurrence in these young patients. And when we look at the meningioma, this study from the European group with more than 4,500 patients with a long time follow-up, we see that it's mainly skull-based meningioma that are treated with 67% of them. And you can see here the global control. So again, compared to the Schwannoma, meningioma are more likely to be loco-regional pathology. And you can see that with time, you can have some drop of the control, mainly in grade 1 meningioma, but still the control rates can be as high as 80% on the long run. This is another case of combined treatment. That was a vestibular schwannoma with the cystic compound that was compressive. So first we did surgery for removal of the mass, and only this small remnant intracanaliculaire was treated, which was less than 0.2 cubic centimeters. So for pituitary adenoma, we can improve the hormonal status and have this quite regular volume decrease. So tumor control, as you can see again, for benign tumors, most of the cases are beyond 90% here in different series from literature. And for the control of secretion, of course, this will be less, and usually it's from 30 to 70%, depending on the type of secretion. Craniopharyngioma also are complex lesions that can be well controlled, mostly after first surgery, as here this was a remnant that is well controlled with the radiosurgery. And you can see here, same problem with the involvement of the optical pathways, but again, the dose is still tolerable for the optical pathways to avoid any damage to the optic nerve. Brain metastasis has been a revolution in this field of radiosurgery, because now we have a tool that allows almost curative treatments. We can treat multiple brain metastasis almost with no limits of numbers. We can see here we can have long survival, more than 7 years with these patients well controlled. We can treat up to 20 lesions in one single session in less than 4 hours and still have an excellent response. By the way, the rate of response again for metastasis is really excellent. And of course, the survival is depending now more on the oncological sites. For some large lesions, we can develop now the so-called stage dose radiosurgery with 2 stages. One first stage to reduce this large volume, and then a second stage for a better control. We usually give 1 month delay between the 2 stages. Here, another case treated in the same fashion, and you can see here results from 30 cc's for this large mass that draw to 2 cubic centimeters 1 month later and could be completed with the second stage. And we have now some cases and also in the literature that shows a better control for this large lesion with this kind of protocol. So some more challenging cases regarding the glioma. Glioma, of course, are diffuse pathology, but in some cases like here, they can be focal, and they can be targeted with radiosurgery. This was a pilocytic astrocytoma in a child in the brainstem that has been first operated. We did only biopsy and evacuation of the cyst, but unfortunately, as you can see here, the cyst recurred some months later. So we then decide to do radiosurgery plus puncture of the cyst. And you can see here the follow-up, more than 10 years, and the child is perfectly controlled. So for pilocytic astrocytoma, as in this case, the control at long run can be very interesting, again, because in benign tumor, the control are very high. In some cases of large tumor, if we do a careful selection, like in this case, of course, we can ask about surgery, but when we analyze carefully, this lesion is coming from the cavernous sinus and have the characteristic of cavernous hemangioma, which are highly sensitive to radiosurgery. So we decided to do this radiosurgery with only 9 grays, sparing perfectly the optic pathways. And you can see here the response, which is almost complete disappearance with preservation of vision. And we are now more than 8 years follow-up for this patient. So, of course, in our area, we have to deal with some large lesions. And sometimes the radical resections for this can have a high morbid mortality rates. So the so-called combined approach can be interesting. The criteria for selection, of course, we need to have benign and slow-growing lesions. Most of them are first operated, and no CSF disturbance, no clinical signs related to tumors. So selection criteria are very important. Here, another case of large pituitary adenoma that has been operated with large residue and combination of radiosurgery and medical treatment could almost make it disappear with now more than 8-year follow-up. So stage radiosurgery also for these complex cases. We have some cases of benign tumor that have been operated on, but still large residue, and we can do two-stage volume, as you can see here, and the controls, you can see a very good control, like this patient, 12 years follow-up of this large petroclival, and now perfectly functioning and normal return to daily life. So many cases, we did some assessments of the patient satisfactory survey, and the global experience was good for more than 90%. The patient's information is very important, and we insist a lot to have a clear and honest information and consent of the patients. And you can see that the positive opinion of this technology is above 92%, which is more or less in correlation of the efficacy of the technique. So when we compare to other technologies, of course, the first point is to avoid radiation therapy in young patients with benign lesion. This is one of the most important message, is as long as we can offer radiosurgery to our patients, this is much than radiosurgery, than radiation therapy, because of its complication, as you can see here. And the second aspect is when you are treated with gamma knife radiosurgery, we have to be aware that the dose is heterogeneous compared to other technologies where we have homogeneity of the dose. And of course, you can see the dose distribution is different between the technologies. So one should pay attention when selecting the best technology for some cases. Here, example of cases that has been planned on different machines, and you can see that for this case of vestibular schwannoma, only the gamma knife was able to spare perfectly the cochlea in this case that has been planned on 4 different machines. Same on multiple metastases. When you are treating on other technologies compared to gamma knife radiosurgery, as you can see here, you are having a huge or large amount of brain that will be irradiated beside the lesions, and this is superiority of the gamma knife. Same regarding the dose to the body. You can see here the gamma knife is the lowest regarding irradiation of the body, and here are also this comparison between different techniques. So there are fundamental differences between the techniques that one should know to better select the machine for best indications. In conclusion, the gamma knife icon is a neurosurgical tool in the lineage of its predecessors. The Lexel gamma knife icon allows to broaden the field of application of this technology, allowing more patients to benefit from its high efficacy and innocuity. And we consider that this is a true chance for our patients because of some conditions where the treatment would be otherwise impossible. reduce morbidity and intensive care stay, decrease the transfer of patients abroad. So we are able to treat all our patients locally. So our challenges, as I said, are some large lesions, which are most challenging. Sometimes in some area, the surgical conditions are not so good, and morbid mortality can be still high. So again, we are insisting that the microsurgery needs to be developed alongside with radiosurgery. And we think that the required criteria to set up radiosurgery in our countries is first to have a good level of neurosurgery in the country, sufficient number of neurosurgeons, availability of diagnostic tools, CT scan, as we heard, MRI, experienced multidisciplinary team, and of course, university hospital with high and competent team to take care. This is our team at the University of Rabat, with, of course, all our partners, radiation therapists, oncologists. This is a multidisciplinary approach and work. And I thank you for your attention.
That was a great talk. Thank you, Dr. Melhaoui. This is wonderful what you're doing in Morocco. How many radiosurgery centers are there in Morocco, by the way?
We have started in 2008 with this project, which was a neurosurgical project. That was the first one. And then, as I said, fashion of radiosurgery came through. So nowadays, almost the radiation centers are claiming to implement radiosurgery with some questionable other technologies. But I would say at least 2 or 3 other centers are capable of doing or having machines claiming to do radiosurgery, because when we see the real radiosurgery programs, which is single dose, there are very few. Most of them are using them mainly as radiation therapy centers, and are programs that are managed by radiation therapists, and the philosophy of treatment is very different. We are really pushing that this, at least for the brain, the radiosurgery could be next to the neurosurgery department, and the neurosurgeon can be really the leader and manage this case on its own. This is, in our vision, very important.
What is the population of Morocco?
We have about 33 million inhabitants.
So that means we still need a lot more, right?
Exactly. Of course.
Great talk. Thank you very much.
Thank you.
Thank you, Dr. Melhaoui. Our participants will have definitely learned a lot from your presentation about stereotactic radiosurgery and its applications. Now, I'll move on to the second speaker. Mr. Kumar is the business line director of neuroproducts of Electa and has been associated with Gamma Knife and other stereotactic products of Electa for the past 20 years. Mr. Anoop Kumar will be talking on why stereotactic surgery should be part of the Neurosurgery Armamentarium. It is an honor to have you with us, Mr. Kumar. Over to you.
Good morning and salam alaikum. Am I audible?
Yes, you are.
Hi. So thank you very much for giving me an opportunity to present a few slides in front of you. And I sincerely thank Professor Melhaoui to giving a very wonderful presentation. In fact, in front of Melhaoui and the other distinguished dignitaries, I'm no one to give a clinical talk. As you know, my disclaimer is that I work for a company. So, and at the same time, I'm not going to do a marketing talk or something. I'm just telling why a stereotactic radiosurgery should be the part of the armamentarium. So with your kind permission, let me start my talk. So I've been working with Electa for almost like 24 years. I have been with Electa through the different levels of the stereotactic development. We have the product which is very much dedicated for the brain stereotaxy. We are also having the products that can give radiation to the entire body, or even stereotactic radiation to the body as well as this one. But why the principle that Elekta still believes and making one specific equipment very much focused on the brain radiosurgery is different. With as Dr. Melhaoui, as Professor Melhaoui has really mentioned, stereotactic radiosurgery was conceived by the team of neurosurgeons. How can I remove my, okay. So the stereotactic radiosurgery was conceived by a team of neurosurgeons and physicists in Sweden almost like 50 years ago to deliver radiation to the target in the brain while minimizing injury to the adjacent area. So this is the main principle behind the thought process of why should there be a stereotactic radiosurgery. The main principle is that to minimize the injury to the adjacent area. And then the benefits of stereotactic radiosurgery, Professor Melhaoui has really explained it very well, but I am just again telling you, it offers a very fast recovery to the normal life for the patient. To be very honest, people may think that the radiosurgery is expensive, but if you look at the real cost that is happening to the patient, it reduces the cost per patient, because any patient who is undergoing a neurosurgery, whether it is a free, even if it is a free, there is a long convalescence period. There is a long, what you can call the period which he takes to come back into the normal life. And if this person is what you can call a earning member of the family, the social impact is very, very huge. So when a patient undergoes a radiosurgery, get it treated, and he is active from the earliest possible day, because in many cases, from the next day, the patient can continue his normal work-day life. So if you look into the entire social economic factor, radiosurgery is having a very big benefit. The radiosurgery also offers a large patient throughput through the hospital. The reason is that in a hospital, you have all the facilities. You may have a very wonderful operation theater. You may have a digital subtraction angiography suite to do the interventional neuroradiology, and you may be doing a lot of surgeries as well. But if you have a radiosurgery unit, a lot of patients could be transferred to the radiosurgery unit where you can spend your time to give what you can call utmost care for those patients who need invasive surgeries and other interventionals. The other benefit of the stereotactic radiosurgery is that no intensive or minimal post-operative care are there. And if you look at the systems like our systems, a few support staff is required. So this gives us a lot of what you can call the efficiency as well. And another 2 points I mentioned in red dots are the low operating cost, reliable and documented long equipment lifetime. These are very much vendor specific. And what I mean by vendor specific is that sometimes you may look that equipment may be low cost to buy first, but it may be having a long, what you can call operation cost. The cost to run those machines, the cost for servicing the machines, cost for maintaining that machine over a period of time will be having like a balloon factor. Whereas there are some machines where you may find that the initial investment may be looking a little bit high, but ultimately what you can say that you are not spending any much money on that. So that's another thing. Then of course, the long life, we need to have the machines which gives the confidence of accuracy and efficiency throughout the equipment lifetime, which means we are talking about the machine with minimum moving parts, with the machine with what you can call very turbid, this one. So why SRS is very much needed in the growth is that there is a significant potential of the stereotactic radiosurgery going forward, because every year 15 million new cases of cancer is diagnosed every year. Out of that, by 2030, it has been predicted that 24.6 million new cancer cases will be there. And 20 to 40% of these cases can develop into brain metastasis. The reason is that with our new, what you can call the medical oncology, with the new devices, we are able to improve the lifespan of the patient. So when we are improving the lifespan of the patient, the probability of metastasis increases. And that is where the intracranial SRS is going to be increasing. And this is a study done in the US, which clearly tell that by 2023, what is going to happen is that there will be a normal growth for the surgery, imaging and diagnostic, radiation therapy. These are all, they can see the normal growth happening. But when it comes to the stereotactic radiosurgery, it is going to increase a lot. The main reason is that if you look, even when you're talking about the body radiation, people are now trying to think, why should give a body SRT? Why can't we do the SRS for the body also? So stereotactic radiosurgery is going to really increase. One of the main reason is that more and more guidelines are coming, telling that you need to have try to do maximum stereotactic radiosurgery for the brain. The reason is that they have found when you're doing a whole brain radiotherapy or a stereotactic or a what you can call a brain radiotherapy itself, you are seeing that there will be a big possibility of declining of the cognition. You are giving a good treatment to the patient, you are improving the lifespan of the patient, but if the cognition is going down, it's not good for the quality of the life. So it's very important that we improve the lifespan, but at the same time maintain the quality of the life as well. That is where the importance of stereotactic, accurate, precise stereotactic radiosurgery for the brain sets in. And now what is happening is that because of the clinical evaluation, aging population is coming up, technology progress is there. That means high quality imaging is there. So we are picking up the necessary indications in the brain that need management very fast. There is also environmental pressure because operational efficiency for the hospitals are there because you need to treat as much as patients possible. So you cannot do all the time doing the operations and limit the number of the patients that can get benefited from your service, but you can also pass a few patients to the other department of stereotactic radiosurgery where they can get their treatment with the machine. So, you know, in the same hospital, you can classify the patients for those who need real invasive surgeries and those who could be managed with the stereotactic radiosurgery. So the ultimate goal in stereotactic radiosurgery is that treat but preserve the healthy brain. And that is where the technological difference between the stereotactic radiosurgery platforms come into place. So, wow, how a gamma knife or our product will give that benefit is that this is a very simple thing. Like this is the exact area you need to treat. But with many other technological platforms, you definitely need to add a sort of a margin. And if you look at the margin itself is a volume. It can be done in a body where the body cells can repair the damage. But as you all know, brain cells, once it receive a radiation, cannot repair. So if you look, this is actually what we need to treat. But in many cases, if you are using a different technology, you are treating unwanted healthy brain as well. So this is very clearly mentioned in one of the study in Radiation Oncology Journal. In spite of difference between the platform in conformity metrics, the greatest impact on the normal tissue dose was made by the PTV margin applied. And when you are using a technology like gamma knife, where we don't use the PTV at all, you are saving a lot of normal brain. And the preservation of the normal brain helps in maintaining the cognition of the patient. Here, I just give a slide. I'm with the courtesy from Lexel Gamma Knife Society. And I need to make a disclaimer here. Lexel Gamma Knife Society is not the part of Electra. It is a platform of the consortium of the doctors and the clinicians who are using our gamma knife. And as per the Lexel, what you can call the Lexel Gamma Knife Society, they have clearly evaluated the pattern of the indications in the brain that are able to be treated with the system. And if you look that there are so many indications like AVM, cavernous malformation, functional disorders like trigeminal neuralgia, essential tremors, benign tumors such as meningioma, pituitary adenoma, vestibular schwannoma, craniopharyngioma, even malignant tumors like metastasis, multiple metastasis, GBM, and even uveal melanoma. They have identified that the incidence of these indications per million are like this. But all the patients could not be treated with the stereotactic radiosurgery. So in that case, we find that these are all the percentage of the people who could be treated. And if you look in a 1 million, there are minimum 532 patients who are eligible to get a precise stereotactic radiosurgery system in every population. In 1 million, 532 patients is the minimum one. So the main point is that, and from the same Lexel Gamma Society, we have noticed that all the indications are showing a sort of what you can call the upward trend. So the point what I'm coming here is that your hospital will be having all the tools to give the care to the patients from an invasive perspective, from a interventional perspective. But having a very dedicated brain precise stereotactic radiosurgery program in a fully functional neurosurgery hospital is a must. Thank you for your attention.
Thank you, Mr. Kumar. Thank you for highlighting the significance of stereotactic surgery in neurosurgery and its feasibility through this platform. Truly remarkable. Moving on to our third presentation now, our third speaker for this session is Dr. Kiran Aftab, Research Associate in the Department of Surgery at the Khan University Hospital here in Karachi, Pakistan. She is a graduate of Dow Medical College, Karachi, Pakistan, and has completed her master's in neuroscience from King's College London after securing a Chevening scholarship. Her research interests include MRI image processing and analysis, and she is currently working on developing non-invasive AI-based diagnostic algorithms in brain tumor patients as part of the AKU Neuro-Oncology Group. Dr. Aftab will be talking about the impact of AI in management of brain tumors. Dr. Aftab, you have the floor.
Assalamu alaikum. I hope I'm audible. So I'll be talking about the impact of artificial intelligence on the management of brain tumors. So if you look at the current treatment approach or the process that is followed for the treatment of brain tumors is that the patient presents to a neurosurgeon, the imaging is done, and following a suspicion or a clinical diagnosis, they proceed for a surgery, and then a sample is taken for histopathological evaluation, and then further treatment options are explored or provided to the patient. But then how can AI help in this whole process? So there are many steps. For example, when we are looking at the histopathological evaluation, which is done for the grading and detection of certain genetic mutations, that is where AI can make the process more accurate and more timely and more efficient. And then when we're planning the different treatment modalities, it can give us information about response to that certain modality. It can also tell about whether the response is like, if there's a true progression of the tumor following the treatment, or there's pseudo progression, or it can also help us in predicting the survival of the patient using the clinical features, the radiological features, and even the genetic information. So there are a lot of ways. In my presentation, I'd be focusing on how the imaging or MRI-based information can be used to develop these AI models. So before proceeding further, let's just have a look at what AI is actually, because I'll be using a lot of technical terms here, and it's better to go over them first. So artificial intelligence, we all know, is when the machine is trying to mimic how the human brain works or how the humans perform. And you are basically teaching it how to assimilate different forms of information. So machine learning is a subset of, or a subtype of artificial intelligence, where you are basically developing algorithms where the machine is learning different patterns, and then it's able to predict further information based on those patterns. And then within machine learning, we have this type of algorithm, which is called neural networks. And this is based on how the human brain is structured. So there are layers that are connected, just like interneurons are in the brain. And then there's a further subspecialized type of neural networks called deep learning, and that includes an example here is CNN, or convolutional neural network. And then you'll see words like supervised learning, unsupervised learning, and then there are further types of machine learning. Supervised learning is basically when you're labeling the data that you're providing to the machine, and unsupervised and when that data is not labeled. And then there are further subtypes of supervised learning, such as support vector machine, random forest, decision tree. Then you'll come across this word segmentation, where you're basically trying to delineate the tumor from the rest of the healthy or the rest of the brain. And we're trying to automate this process with the help of AI, and that is called automated segmentation. You'll come across predictive modeling, because a lot of times we are taking some sort of information and we're trying to predict the outcomes or predict the different events that we think would happen. When we look at studies, you'd come across data sets are divided into training and test components. So training data set is where you're giving the computer or the machine the information that this is the data and these are the patterns, and you let it learn or observe those patterns. And then you provide a test set for it to actually predict on the basis of what it has learned. Sometimes there's also a validation data set. For every machine learning model or classifier, there are always some sort of performance analysis, and the performance parameters that are mentioned usually are accuracy, sensitivity, specificity, and you'd also come across AUC, which is the area under curve for receiver operating characteristics. So those are some important terms that you just need to know, because we're at the end of the day, you're looking how accurate or how applicable your model is. Then in the corner, I've mentioned radiomics and radiogenomics, and we'll look at what it is. So this is an image that was part of a recent publication that we just had in the Journal of Neuro-Oncology. And here we have shown the whole pipeline of radiomics. So radiomics is basically when you're extracting information from MRI or any other imaging modality, and you're basically extracting information in the form of quantitative measures, and then you're using it for further analysis. In terms of brain tumors, we basically begin with acquisition of MRI scans or PET scans or even CT scans, and they undergo certain standardization because every center, every MRI scanner has different protocols. Next, the image is segmented. So we want the tumor to be differentiated from the rest of the brain. And as you can see this picture, it's a GBM, and it has been further segmented into the edema, non-enhancing tumor, and the enhancing tumor. And then these, we have written ROIs, it's basically regions of interest. And those regions of interest are labeled on different MRI sequences. The next step is feature extraction, when you're basically trying to get all this information that is on imaging in the form of quantitative variables. So there are simple things like the size of the tumor, the volume of the tumor, the texture, intensity changes, but then there are certain advanced features as well. So if you look at studies, we would come across like features in hundreds. So that is all the quantitative information, but then we don't want all those features which maybe are just redundant, which are not as relevant for our objectives. So the next step is feature selection. Here again, we have some machine learning algorithms that select those features that are most relevant for the objective. And then this information is combined with the clinical features and the genetics information, and then it is used for predictive modeling. So let's come back to how AI can transform the management of brain tumors. So we begin with how it can change the diagnosis of brain tumors. And we have recently completed this study and published it in IEEE. So we use machine learning to basically differentiate brain tumors from other forms of infections of the brain, such as tuberculosis, bacterial infections. And we used, radiological features in it, such as the ring enhancement, T2 hypointensity. So we had a list of features. And then we used correlation matrix for the feature selection just to get those features that were most relevant for our study. And then we used logistic regression and random forest as two models. And as you can see, we used some balancing techniques as well. And after those techniques, logistic regression gave us the best results. Another aspect of AI in brain tumor diagnosis is automatic brain tumor segmentation. So BRADS is basically brain tumor segmentation challenge that was started a couple of years ago. And the purpose was to, so basically what they did was that they provided some data, some brain tumor data, which was labeled and it was accessible publicly. And then they challenged people to develop algorithms for the best segmentation. And as you can see on the screen, how the tumor can be segmented in not just the tumor versus the brain, but also the different subregions of the tumor, for example, the active tumor, the tumor peritumoral edema, and all. Another important aspect of brain tumor diagnosis is grading the tumor. So what we want is, the first information that we want is whether it's a low-grade tumor or a glioma or a high-grade glioma. So in this study, they developed a classifier and they used advanced multiparametric MRI and texture features that are extracted from the conventional MRI. And with the help of this classifier, they were able to grade tumors with an AUC of 95.5%, which is a very good, which is considered excellent. Few other ways how it can improve the diagnosis. For example, it can be used to classify the different subtypes of gliomas. In this study, the first image shows a differentiation between atypical low-grade oligodendroglioma versus anaplastic oligodendroglioma. And we can see how it appears on the images. But the machine was taught to differentiate between the two types of oligodendrogliomas. Another very important aspect is prediction, the genetic mutation. So now we know that the brain tumor classification majorly relies on genetic mutation. And this is an information that we can only retrieve after we have a biopsy, and it's an invasive process at the moment. But there's a way of doing it non-invasively where you can actually predict the presence of these mutations with the help of radiomics. And in this study, they used deep learning to basically predict the presence of 1p19q codeletion. In the first image, you can see there are three images, and the red voxels indicate codeletion. And in the second image, you can see the green voxels, which predict non-codeletion, and it has been quite accurately predicted. It's not 100%. Another very important aspect of brain tumor management is prognostication, or predicting the outcomes in these patients. So a number of studies have been done on that as well, where they used conventional MRI sequences to extract information from MRI scans. And then those features were used to predict their survival. And it's a Kaplan-Meier curve that shows how the patients were stratified into low risk and high risk. So going a bit of more like making it more sophisticated is when you add multi-parametric MRI, when you're combining different modalities, and you're also going for advanced MRI modalities. And it was seen that these models provided better accuracy. They were more accurate in predicting the survival compared to the conventional MRI models, or even when the clinical predictors were taken to predict these. Integrative models are quite advocated nowadays because, as I just mentioned, we all know that genetic mutations have a very strong role in how the tumor behaves. And when you combine that information with the MRI or the imaging-derived radiomic features, we expect an improvement in these models. And this can be seen here. So when clinical, genetic, and radiomic features were all combined together, it was seen that it gave the best AUC for predicting the overall survival as well as the progression-free survival. And there are basically two studies here that I've shown. In the second study as well, they used 3 different models. And in the third model, you can see that the AUC is highest. The third major aspect of brain tumor management, which is what treatment you're offering to the patient. You've got the diagnosis, you've sort of predicted the survival, and now what is the best possible option for the patient? Again, treatment depends a lot on the genetic status of the tumor. The tumor is quite heterogeneous, and you need a lot of information that we do not have. So that's where radiomics helps us. In this study, it was used to predict the response to treatment, and it was seen whether there is true progression versus pseudo-progression when patients were given chemoradiotherapy. Here again, they included MGMT promoter methylation status to improve the accuracy of the models. In this study, they used diffusion and perfusion imaging to predict response to bevacizumab treatment in patients with recurrent glioma. And you can see the accuracy was 0.78 for overall survival, and it was 0.82 for progression-free survival. Another important thing is planning surgery. For example, there's subtotal resection, there's total resection, and we want to see which patients are going to benefit more from either of them. So in this study, they basically used tumor surface regularity to evaluate that or to predict that. And they were able to not only predict the response, but also the overall survival. So we can see that they basically stratified patients into high and low risk for or responders versus those who will respond less to total resection versus subtotal resection. So, so far I gave some examples of how we can see that brain tumor management can be transformed from AI, and it shows a lot of hope. But then the question comes, even after all these studies, why still we don't have all of this in clinical practice? Why is it not benefiting the patient? So there are a couple of challenges on the way. So the AI models that have been developed so far do lack the robustness and reproducibility that we need for clinical practice. The data that is available is, or I would say the high quality data is not very much easily available, which means that these studies are always based on small sample sizes. There's a lot of variability because of every center has its own image acquisition protocols. And then segmentation and feature extraction process. So this process is also not as robust or reproducible so far. And then there's this problem in machine learning, which is called as underfitting and overfitting. So overfitting is when you have a lot of high dimension data, and underfitting when you have a small sample size. So in these cases, the results may be underestimated or overestimated. So here are some solutions that are proposed, and we hope that once they are implemented, one day we'll be using these AI algorithms in our clinics. So to improve the availability of data, it is suggested that there should be collaborative projects with large-scale data sharing between different institutions. A lot of standardized steps have been recommended for image acquisition, such as intensity normalization, voxel reslicing, and standardization of signal intensity. So there are a few more steps. The whole purpose is basically to bring all of the images that are in that data set to one level so that they can be easily compared. And then, as I said, there are a lot of features and they can be overfitting and underfitting. So then feature selection methods such as PCA or autoencoders are helpful in that sense. And then balancing techniques that we also used in our own study has been very helpful in improving the results. So finally, this is what we proposed. This is a plan that we have proposed to different platforms, which is virtual biopsy. And we propose it for the classification, outcome prediction, and treatment planning of brain tumors. So it begins with when the patient presents, we collect the clinical data, including the demographics, functional status, and the survival status. So this is all clinical information. And then we also combine or collect first the histopathological data, which includes the genomic data, the important mutations that we see, like P53, IDH, 1P19Q, MT, but also the microRNA status, which is a very upcoming field, and our lab is working on that. So all of this information is collected. On the other hand, we have got MRI scans, which are annotated for the tumors, and then they undergo certain pre-processing and feature extraction, so that those features are then combined with the genetic information and the clinical data that we also collected, and they are used to build radiogenomic models. And these radiogenomic models can be used to not only diagnose tumor, but also predict survival and plan different treatment options for the patients. So these are some articles that I find really helpful if you're interested in studying more about AI and how it can be used in neuro-oncology. Thank you.